Hello and welcome to the third installment in the 12-lead ECG interpretation series. This lecture is going to review your understanding of the ST segment and how it relates to the coronary vessels and when it is appropriate to cause STEMI in the field. As previously mentioned, this presentation has been developed for my paramedic students to use as a follow-up to their daily in-class lectures. In today's presentation, we are learning about the myocardial coronary blood supply. We will be able to name the major coronary arteries and the regions of the heart to which they supply blood, discuss the benefits, limitations, and pitfalls of ECG evidence in acute myocardial infarction, recognize ST segment elevation, ST depression, T-wave inversion, and pathological Q-wave formation. Describe the ECG presentation that indicates reciprocal changes on the cardiac machine. And describe which leads are related to the various areas of the heart and a systematic approach to assessing 12 leads using the ICL leads methods to find an MI. First of all, we're going to go through and review the coronary blood supply to the heart. It is important to recognize that just because the blood travels through the inside of the heart, no blood is actually diffused into the heart muscle here. In order to get blood diffused into the heart muscle, making oxygen and nutrients available for contractions to occur, there must be a clear path through the coronary arteries that run on the outside of the heart and into the tissue. Just above the aortic semilunar valve, the right coronary artery delivers blood via gravity to the right ventricle, the inferior wall and posterior wall of the left ventricle, the SA and AV nodes in the majority of our patients, and also the posterior fascicle of the left bundle branch. Additionally, the left coronary artery feeds the anterior wall of the left ventricle as well as the right and left bundle branches and Purkinje fibers in the left ventricle. And it does this through the left anterior descending branch of that left coronary artery. Now the circumflex branch of the left coronary artery, it feeds the lateral and posterior walls of the left ventricle and also the SA and AV nodes in a small percentage of the patients that we deal with. Now that we have briefly reviewed the coronary blood supply, let's talk about the ECG changes commonly seen in an in the setting of an acute myocardial infarction. First of all, there is a hierarchy to triage the chest pain patient. Is this a ST segment elevation or a new onset of a left bundle branch block? Are there T-wave inversions or ST segment depression, or is this considered a non-diagnostic ECG? ST segment elevation indicates injury to all three layers of the heart muscle, and it should be counted if it is higher than 1 millimeter or 2 millimeters in the septal leads. Also, ST elevation needs to be present in 2 or more related, or as they refer to, contiguous leads. In this slide, you can rapidly identify ST elevation in leads 1 and AVL with reciprocal changes, also known as the mirror image, in leads 2, 3, and AVL, which depict ST depression. The other causes of ST depression include ischemia or a subendocardial injury where there is a lack of blood flow to only a couple layers of the heart. And also some meds like digitalis can cause ST depression in a 12-lead. If all you see is ST depression without the associated ST elevation, then this indicates hypoxia and may be quickly reversed with proper treatment. Here you will see ST depression in leads 2, 3, and AVF, with associated ST elevation in leads 1 and AVL. If T waves are upside down, then this is an indication or an early warning sign of an acute coronary syndrome and ischemia. Make sure you get a baseline 12-lead ECG prior to giving nitroglycerin, since you will most likely reverse the effects of the ischemia. Always do a before and after 12 lead so the receiving facility can confirm the existence of acute coronary syndrome. In this presentation, you will note T-wave inversion in V4, 5, 6, 1, and AVL. Now, pathological Q waves signify tissue death, and in order to call a Q wave pathological, it has to be more than 40 milliseconds wide, or 0.04 seconds, or a third the height of the R wave. Now that you know about the significance of the ST elevation, ST depression, and T-wave inversion, and pathological Q waves, let's take this information and apply it to the findings of a 12-lead printout. For purposes of this course, we will use the Bob Page's I See All Leads to help us in our interpretation. I stands for inferior and relates to leads 2, 3, and AVF. S stands for septal and relates to leads V1 and V2, while the A in I See All Leads stands for anterior and relates to leads V3 and V4, and the L, or leads, I See All Leads L, stands for lateral and relates to leads V5, V6, 1, and AVL. We spoke previously about the mirror images, or the reciprocal changes, and on this slide you can see that the reciprocal changes relate to either 1 and AVL or 2, 3, and AVF. In an inferior wall MI, we are seeing ST elevation in leads 2, 3, and AVF. And as shown in this picture, the blood clot is occluding blood flow through the marginal branch of the right coronary artery, causing a mirror image of depression to be seen in the lateral wall, or leads 1 and AVL. This is what the 12-lead ECG would look like in that inferior wall MI, with ST elevation in 2, 3, and AVF, and the mirror image, or the reciprocal depression, in leads 1 and AVL. In septal wall MI, the ST elevation will be seen in V1 and V2, and since this is the center of the heart, there won't be a mirror image, so there is no reciprocal changes to be found with a septal wall MI. In the anterior wall MI, the clot is occluding the left anterior descending artery and shows ST elevation in V3 and V4 with a mirror image in the inferior leads, or 2, 3, and AVF. This is an example of what an anterior-septal wall MI would look like on a 12-lead printout. You can see the ST elevation in V1, 2, 3, and 4 with the reciprocal changes in 2, 3, and AVF. In a lateral wall MI, there is a clot in the circumflex branch causing ST elevation in leads V5, V6, 1, and AVL. In this case, the mirror image would be on the inferior wall, which is 2, 3, and AVF. This is a 12 lead representing a lateral wall MI with ST elevation noted in 1 and AVL, with the reciprocal depression in 2, 3, and AVF. Alright, let's try a couple for practice and see how you do. Here's the first one. Using the IC all leads, where is the MI located? This is an inferior wall MI with ST elevation leads 2, 3, and AVF, and you will note reciprocal depression in leads 1 and AVL. What artery is occluded in this inferior wall MI? If you said the right coronary artery, then you are correct. Here's your next one. Where is the MI located in this 12 lead? If you said lateral, you're correct. What artery is occluded here? If you said the circumflex branch, you are correct. Alright, here's the last one. Where is your MI? If you said anterior-septal, you are correct. What artery is occluded? If you said the left anterior descending of that left coronary artery, you are correct. This completes the final installment of my 3-part series on 12-lead ECG interpretation. Please keep an eye out for future lecture series on paramedic education topics, and I'll see you in class.